Now, this is a very controversial artwork because there's ongoing debate about the artist Louis Wayne. There are some people who claim that his later artwork shows signs of schizophrenia, whereas he became very famous for these anthropomorphized cats. He was drawing all these cartoons, and it relates to his wife because his wife was dying of cancer and their tomcat really comforted her. So he started drawing a bunch of pictures of cats. And then they claim that over the period of his career, these paintings got much, much more abstract and much more in line with symptoms of schizophrenia. However, counter arguments to this theory argue that he didn't do these paintings in this particular order, but they were more mixed up. So not necessarily showing symptoms of schizophrenia. But this does kind of show this detachment from reality and the kind of psychosis symptoms that can occur in suffering from schizophrenia. So in terms of the onset of schizophrenia, 1% of the world population suffers from this disorder, and typically it's going to emerge between the ages of 18 to 24 years old. That's the average. So me, I'm past that date. So I'm pretty sure that the onset of schizophrenia is not something that I am going to have to worry about in particular. Now, in terms of gender, it does affect both genders equally in terms of the number of people who have schizophrenia in the world. However, men tend to suffer more severe delusions and more severe symptoms. Now, what's the reason for that? Well, it could be that there are gender differences biologically that are resulting in men suffering from more severe symptoms, or it could be gender roles. The sociocultural model that is playing a role in sufferers of this disorder. For instance, women have a tendency to seek medical care much more often than men do. It's part of the reason that women have a longer life expectancy. So if a woman goes to the doctor, it's more likely that her symptoms are going to be addressed and she is going to get treatment for her symptoms sooner than a man might. And so the sooner you get treatment for schizophrenia, the longer you can go without symptoms, or the symptoms don't get as severe. Untreated schizophrenia can lead to very, very severe symptoms. So if you go through a long period of time without going to the doctor, and you don't know that you're having delusions or paranoia or that reality is shifting, then it's only going to continue to get worse. So it may be that, yes, men and women are both susceptible to schizophrenia, but due to sociocultural models, women are more likely to go to the doctor and have that caught sooner rather than later. So where do we get the term schizophrenia? Well, schizophrenia is a literal term that means split mind. Now, this can get confusing because a lot of people will think, oh, split personalities, multiple personality disorder, or DID, that's different. What they mean by split mind, it doesn't mean, oh, we have a bunch of different personalities. It means that you're splitting from reality. And so the more severe symptoms of this disorder are going to include disorganized and delusional thinking. This could be like word salad where you're not able to speak coherently, or you have grandiose beliefs like you're the president of the United States or someone's out to kill you. Disturbed perceptions. This is when you may hear things or see things that aren't actually there. So kind of like hearing voices in your head. Inappropriate emotions and actions. That could mean a complete lack of the expression of emotions, like a flat affect, or it could be like a symptom called waxy flexibility, where some people with schizophrenia have negative symptoms, meaning that a behavior that's supposed to be there is absent. So some people with schizophrenia that are in long-term care facilities suffer from waxy flexibility, which means that they will sit or stand in a position for hours on end, completely unmoving. And even if someone tries to move them, like if I'm sitting here with that symptom and they lift my arm up, then I will stay in that position. I will hold it like a mannequin or a wax doll. So there are going to be positive symptoms and negative symptoms. Positive symptoms don't mean good. It just means the presence of inappropriate behaviors. Negative symptoms doesn't mean bad. It means the absence of appropriate behaviors. So something that's supposed to be there isn't, or something that's not supposed to be there is. So some positive symptoms of schizophrenia can include hallucinations and delusions and disorganized speech, referential thinking. This is when you make connections to things that aren't connected. So like ascribing personal meaning to completely random events. So like if you see a black cat walk in front of you and you say, oh, I need to go back to the house because something bad's going to happen, that's referential thinking. There's no connection between that cat and what kind of day you're going to have, but yet you find a connection. That's a positive symptom. In terms of disorganized speech, some people with schizophrenia will talk completely incoherently, and you cannot they're saying real words, but they make no sense together. And we're going to look at some examples of that. And then in terms of negative symptoms, a flat affect, not having any emotions on your face, or catatonia. All right, this is where we get the waxy flexibility of they'll sit or stand or stare into the distance for hours on end. They can be moved by somebody else, but then they'll stay in that position for hours on end. So first, we're going to go over the positive symptoms. First category being hallucinations. So a person with schizophrenia will see or hear things that may not actually be there. Now, most of these hallucinations are going to be auditory. They're going to be hearing things that aren't there. The most common one being voices. So like voices in their head that don't actually exist. Then to a much, much smaller degree, some people with schizophrenia do have visual hallucinations where they'll see things that aren't there, or they'll feel things like bugs on them that aren't there, or smell toast or gas, or be able to taste things. So that's to a much, much lesser degree. The most frequent symptom with hallucinations is that they're going to hear something that's not there. So hallucinations are false perceptions. You're thinking that something's there when it's not. In terms of delusions, a delusion is a false belief. So this isn't like, oh, I heard somebody say, or I see that thing move, or the walls move, or whatever. This is a false belief that often categorizes itself as a delusion of persecution or delusions of grandeur. So a delusion of persecution could be like one example I've heard in my classes when I was in college was a man with schizophrenia believed that Smurfette was trying to kill him. So he was racing, y'all know the Smurfs, right? So he was racing down the interstate trying to get away from Smurfette. So like imagining that Mickey Mouse is trying to kill you, that's a delusion of persecution. Imagining that the government is watching your every move and they've hacked into your house and they've bugged your phone, that's a delusion of persecution. It's not based in reality. It is a false belief. That you're getting microchipped with the vaccine, that's a delusion of persecution.
The satellite man is burning in between my bottom teeth right now. That's mutilation.
Delusions of grandeur are kind of like narcissistic beliefs, like the belief that you're more important than you actually are. And that's not like throwing shade, like, oh, someone has a high opinion of themselves, but something that's just not possible. Like people who claim that they are Jesus, that they're a reincarnation of Jesus, and they start cults, or they're like, I am the king of America. And it's like, no, America doesn't have a king, or I'm the president of the United States. But that's a different delusion or false belief than the delusion of persecution. So one example here is this morning when I was at Hillside Hospital, I was making a movie. I was surrounded by movie stars. I'm Mary Poppins. That's a delusion of grandeur. They're not saying that Mary Poppins is trying to kill them. They're saying that I am Mary Poppins, and it's just not true. Is this room painted blue to get me upset? That's a delusion of persecution. Someone purposely painting a room to mess with them, to paint it blue so that they'll get upset about it for whatever reason. My grandmother died 4 weeks after my 18th birthday. So it has nothing to do with what's going on. So there we see examples of both delusions of persecution as well as delusions of grandeur. Disorganized speech. This is interesting because this is when they're able to speak words. You can tell what the words are, but they make absolutely no sense, even with context. So like colorless green ideas sleep furiously. That's an example of word salad. It's completely disorganized. It doesn't make sense to anybody. Now, people believe that this symptom may occur because of your selective attention not working. So you're holding one thought and then your attention is diverted to something else. And then your attention is diverted to something else. So like you may be thinking like, oh, water is colorless. And then you're distracted by, oh, what are colors? Green is a color. And you're like, well, what is green? Green is an idea. And then like, what do you have an idea of? I have an idea to sleep. You got woken up that one time by your neighbor. That made me furious. So that goes into colorless green ideas sleep furiously. And it's just like, there's no connection between that because your selective attention is bouncing back and forth too quickly. So people can't keep up. So all of those are positive symptoms. It's important to remember, positive doesn't mean good. Positive means that there are symptoms that should not be there, behaviors that should not be there, but they are. Hallucinations should not be there, but they are. Delusions should not be there, but they are. Word salad shouldn't be there, but it is. That's different from negative symptoms. Negative symptoms is where there's supposed to be a behavior, but it's absent. Okay, so flat affect. Y'all may remember that when we talked about emotions, that an affect is an emotion. It's not the noun or the verb that you're thinking of, like effect versus affect something. It's talking about emotion. So if you have a flat affect, that means you have no emotions showing on your face. It could also be inappropriate affect. So if you show no emotion, that's flat. If you show inappropriate emotions at the wrong time, like laughing at a funeral, crying at a funny movie, that would be an appropriate affect. So it's negative because it's not there. Normal sets of emotions are not present. The more severe or noticeable negative symptom of schizophrenia is catatonia. So this can include patients continually rubbing an arm, doing repetitive behavior, rocking back and forth. So that's something that we see portrayed over and over in media with people who are institutionalized, that they're just like going back and forth like this over and over again, or being completely motionless, not just like for a few minutes, but for hours or days at a time. So like here we see this position with a man in a wheelchair reaching out with one arm to touch the floor and the other arm to reach up behind him, staying in that position for hours. So I had y'all watch this video of a case study with schizophrenia where it went through what it's like to experience those both positive and negative symptoms. So y'all may remember that positive and negative doesn't mean good and bad. Positive and negative means they're present or they're absent. So positive symptoms are things like delusions of grandeur or persecution, where you have beliefs that aren't true that are present. And negative symptoms are when you have something that's missing, like a flat affect, like you're lacking emotion. That's a negative symptom. Or you're catatonic and you're not moving. Okay, so what were some of the symptoms that y'all remember from this case study, from this video, that were striking to you?
The voices.
The voices, the auditory hallucinations. Auditory hallucinations are more common than visual hallucinations. So as the video started off, you were just like brushing your teeth, you lost a little bit of time, there were some bright lights, and then you start hearing voices from the TV. At first, it's the weatherman who's just talking about the weather. And then he starts saying, they know what you did, and they're going to find you. Like some of y'all are looking at me like you didn't watch the video. So go back and watch that if you haven't. And so you start hearing these voices that are like, they're from the TV. And like even the what you're seeing in newspapers, like the wording changes and it all becomes a threat. Okay, so you see delusions of persecution, that they will know what you did and they are coming to get you. A pizza man arrives at the end of the video and you're just like, I didn't order a pizza. And then these voices in your head say, they're here to kill you. Or, oh no, they know it's poison, don't eat it. You know, poison, poison, like over and over again. So again, that delusions of persecution. Then at the end, you see a woman, a caretaker coming by. She makes a comment, it's like, oh, you haven't been taking your medication. That's a common symptom in schizophrenia, that they'll stop taking the antipsychotics that help prevent those symptoms from occurring. And then like everything changes and they balance them back in reality. Like they open the windows and it's sunny, it's not storming. The TV isn't saying weird messages or coded messages to you. Just kind of giving you some insight into what that experience might be like with schizophrenia. So with that, now we're going to talk about the different categories of schizophrenia, because it's not a one size fits all. There are 4 different categories, the most well known of which is paranoid schizophrenia. That's the one that we see portrayed most often in media. This is where we get the whole delusions and hallucinations. Okay, so the person who's enacting that stereotypical behavior of someone with a mental illness usually falls into that paranoid schizophrenia. So misinterpretation of reality. They either think that they're super important, that they're a god, or that they're some sort of like political leader or religious leader, or they think that the FBI is bugging their microwave and that Obama is listening to them through the microwave, like those sorts of delusions that have no basis in reality and often correlates with emotional agitation. So that's typically how media portrays people with schizophrenia, as extremely agitated and volatile, although that's not always the case. Case in point, with catatonic schizophrenia, this doesn't have mostly positive symptoms. Paranoid schizophrenia is mostly positive. You have the addition of things that shouldn't be there, delusions, hallucinations that are added. With catatonic schizophrenia, you have the absence of things that should be there, like the absence of emotion, so flat affect, or the absence of movement, entering into periods of excitability and then losing that and going into periods of extreme isolation. The disorganized schizophrenia is where you see some positive symptoms in terms of inappropriate affect. So there's flat affect, which is no emotion, which is a negative symptom. And then there's inappropriate affect, which is a positive symptom, like laughing when you're not supposed to be laughing or crying when you're not supposed to be crying. Basically, some very childlike or inappropriate behavior, grinning and laughing, giggling, that sort of thing. And then maybe not paying as much attention to your personal condition, like your hygiene and things like that. So this is where we get the symptoms of word salad, the personality kind of falling apart, and just kind of nonsensical behavior. Now, if you have schizophrenia and you have symptoms from all of these categories and you can't be neatly put away into a single category of schizophrenia, that's where we get undifferentiated schizophrenia. It's not clear cut. Maybe you have canatotic phases and disorganized phases. Maybe you have extreme paranoia and delusions, but you also have waxy flexibility. So there is a category of other for we don't have a particular designation for this yet. So it's simply undifferentiated. So what leads to schizophrenia? What are the factors that impact its effects? Well, we can say with some degree of certainty that dopamine plays a role. Y'all may remember dopamine as the pleasure chemical. It hits your nucleus accumbens, which deals with addiction. But too much dopamine can lead to hallucinations or tripping. For instance, certain drugs mimic the effects of dopamine or neurotransmitters, and that can lead to hallucinations or extreme agitation. And so dopamine is tied to those major symptoms that we see within schizophrenia. So the higher levels of dopamine receptors you have in your brain is tied to the prevalence of schizophrenia. So not necessarily just how much dopamine you have, but how many receptors you have in your neurons to receive that dopamine in the first place. So because you have so many receptors, the dopamine in your synapses is finding a place to land instead of being reabsorbed in the reuptake process. So if you were going to treat schizophrenia, which of these drugs would you prescribe? A dopamine agonist or a dopamine antagonist, and why? Y'all may remember an agonist is a drug that mimics a neurotransmitter. An antagonist is a drug that inhibits a neurotransmitter.
So wouldn't the medicine be an antagonist?
Exactly right. An antagonist would block the dopamine. What it does is it sits in the receptors. So like the antipsychotic medication that they take sits in the receptors on their neurons, preventing that dopamine from getting to their brain, from having an effect. And then eventually that dopamine is reabsorbed in the process of reuptake. So it would be an antagonist that would be the prescribed treatment for schizophrenia. In terms of what this looks like in the brain, you do literally see damage to the tissue caused by schizophrenia. In terms of MRI and PET scans, we see abnormal activity in the following areas: the frontal cortex, the thalamus, and the amygdala. Now, what's your frontal cortex used for? Like your frontal lobe. Good. Critical thinking, decision making, and impulse control. So you see that with people suffering from schizophrenia, they may not be able to make decisions. They may not be able to control inhibition. So like inappropriate affect. You're not supposed to laugh or smile at a certain time, but your frontal lobe isn't restraining that behavior. So you have inappropriate behavior and expressions. Your thalamus is the relay station for your brain. Your eyes send information to your thalamus, which then sends it to your occipital lobe. Your ears send auditory information to your thalamus, which then sends it to the temporal lobe. So all of your senses, except for the sense of smell, goes through your thalamus. Now, how would the thalamus relate to some symptoms that we see in schizophrenia? What could be going wrong there? Exactly right. So if you're having auditory and visual hallucinations, if you're seeing and hearing things, you're perceiving things that aren't actually there in reality, then it could be tied to your thalamus mixing up those messages. It meant to send you something saying, hey, the weatherman's saying it's going to be sunny today. And then instead you start hearing vague, ominous threats coming from the TV. So a mismatch in the thalamus, which is your relay system. What about the amygdala? How could that be affected? What does the amygdala do? Exactly right. It controls fear and aggression. So if you're having delusions of persecution, that could be what's being affected. Your amygdala. You're overly afraid and overly paranoid because it keeps getting overstimulated. Also, some other physical indications of schizophrenia include tissue loss in the brain. So here we see a change in loss in adolescence. So here's a neurotypical adolescent without schizophrenia. Here's a neurodivergent brain with schizophrenia. And you can see the parts of the brain that have the highest rate of loss in that tissue. So near the top of the cortex into the frontal lobe, and then in the temporal lobe next to the ears. So this would make sense why we're seeing auditory hallucinations be more prevalent than visual hallucinations, because your occipital lobe would be more in the back of the brain. And it's mostly the top and the bottom that's being affected here. You also see the enlargement of ventricles in the brain. These are fluid-filled spaces. It's not brain tissue, it's just an empty space. Now, does that mean it's empty of everything? No, there's cerebral spinal fluid, but there's no physical brain mass in that area. So we see a neurotypical brain on the left with much smaller ventricles than the neurodivergent brain on the right, which has a much larger ventricle, showing deterioration of the brain tissue and showing a smaller prefrontal cortex, which can relate to the lack of impulse control that we see in certain types of schizophrenia. So we've talked about signs of schizophrenia. We've talked about there's dopamine in your brain, but what causes the extra receptors? Or they say there's brain loss in terms of tissue damage, but what causes the tissue damage? So this doesn't really tell us about the etiology of schizophrenia. How does it occur in the first place? We're just simply looking at the effects of it. Well, some studies have found that it can relate to the prenatal environment. Most notably, a viral infection in the middle of fetal development. So say around the second trimester, if someone who is pregnant gets the flu or a cold, there is a higher correlation with the development of schizophrenia in that child later in that child's adolescence or early adulthood. So if you contract the flu during that second trimester, you see a higher correlation in schizophrenia. So somehow that viral infection leads to prenatal changes in the fetus's brain that makes more receptors for dopamine and thus results in this onset of schizophrenia once they hit puberty. So that's very interesting to think about in terms of what we're going through in the middle of a viral pandemic. So if the flu can do this and colds can do this, we're just now seeing the first round of babies who are being born from the COVID pandemic. So it'll be interesting to see the longitudinal studies for if there are any causal links between this particular virus and things like schizophrenia. Other genetic factors, obviously, when it comes to twin studies, identical twins versus fraternal twins, you're going to see more of that nature element with the identical twins, because with identical twins, they share the same genetic code, not just the same parents, but the exact same DNA. With fraternal twins, it's the same as any brother or sister. So it's not the exact same egg that is split apart and was fertilized by the exact same sperm. It's different eggs and different sperm, therefore completely different genetics. They just have the same parents. So if you have a higher rate in identical twins sharing the same comorbidities versus fraternal twins or just random siblings, that's a weird way to say it, then you can see that there is a genetic factor in whatever it is that you're studying. So particularly in schizophrenia, you have a 50% higher chance of having schizophrenia if your identical twin also has it. In terms of other family members, if you are the child of two people who also have schizophrenia, then you're at almost a high rate as if your identical twin had schizophrenia, versus looking at the general population of around 1%. So from 1 to around 41%, depending on your relation to that person. But the early onset of schizophrenia is typically going to be like in y'all's age group until around 24. Once you get past that 24 mark, then it's a lot less likely for you to experience those symptoms. So, in terms of nature versus nurture, we have an actual case study of identical quadruplets that all have schizophrenia, but they have different schizophrenia. So we can account for nature. All of them have the exact same genetic code. They're quadruplets. They're identical. Okay. However, all of them have various symptoms or versions of schizophrenia. So I'm going to read this aloud for y'all. Interestingly, the expression of schizophrenia was very different between the quadruplets. Myra, after an initial episode, was never hospitalized and is married. Nora was hospitalized repeatedly, but had marginal adjustment while outside the hospital. Iris experienced more chronic hospitalization, and her symptoms range from severe catatonic withdrawal to times of marginal adjustment when she was able to leave the hospital. And Hester further deteriorated and remains hospitalized. The case study shows that the same genes for schizophrenia can lead to very diverse outcomes, though all quadruplets did develop schizophrenia. The family environment, including parenting skills, were the same for all four, although parents may have treated them differently. However, a difference in treatment is mostly due to the kids being different, so the parents react to the difference of the child. So this relates directly to the Diathesis-Stress Model. Does anyone remember that hypothesis for how disorders develop? That equation for disorders? Yeah, some of y'all are honest. You're like, no, I've never heard of it. We did lecture on it. So diathesis is your genetic predisposition. Let's say that my family has a history of alcoholism. So I know that I am predisposed to alcoholism. Now, is it a disorder yet? No, I just have a predisposition. But let's say I go through a stressor. I lose my job. That predisposition plus the stressor can trigger a disorder. Let's say that I'm not predisposed to alcoholism, but I go through an extreme trauma, like a car wreck or something. Then my stressor was enough to reach the threshold of disorder, even though my diathesis was not high enough. So the higher your predisposition, the lower amount of stress you need to trigger that disorder. Now, there's another part of this equation called protective factors. Let's say I have a high predisposition for alcoholism. I have high stress, but I have a good support network. That can lower the chances of me meeting that threshold and triggering that disorder. So it's predisposition, your genetics, plus stress minus protective factors. Does that or does that not equal the threshold necessary for a disorder? Okay, so this explains why some people can go through the exact same traumatic event and deal with it differently. Also makes sense with this case study. These quadruplets all have the same genetic code, but they could have gone through very different experiences in their lives, maybe being married or unmarried, completing high school or not completing high school, the way their parents treated them. And so this helps us look further into the nature versus nurture aspect of psychology. So how do we treat schizophrenia? Well, obviously you're going to have the biomedical approach, but also a therapeutic approach. Some of them can be more extreme, like psychosurgery, trying to cut off the connections to your thalamus or your corpus callosum that leads to those positive symptoms. But kind of like with lobotomies, it's a lot more rare to have that kind of psychosurgery. I'm not an expert on it, so I'm not going to try and speak on it too much. Behavioral therapy, trying to encourage certain behaviors like consistent taking of medications. So to do this, you create a token economy. What this means is you create something of value to that person. Like if they use it all the time in classrooms, like you're in a classroom and every time you make an A, you get a sticker on your test. Or if you get enough AR points, you get to exchange it for a gift. So you take something that has no value and you give it value. So rewarding behavior in order to make that behavior more common, such as with taking your medications consistently. In terms of the biomedical approach, the most common medicine that's prescribed, antipsychotic medication. That can include thorazine or haloperidol. What this does is it inhibits your neurotransmitter of dopamine from being absorbed to the brain. These antipsychotic medications sit in your receptors to prevent dopamine from getting the messages into your brain. Because remember, like we said before, schizophrenia is linked to having too much dopamine and too many receptors, thus leading to psychosis. Now, the drawback to taking antipsychotic medications is that prolonged use of it can lead to facial tics and involuntary twitching. This is called tardive dyskinesia. So repetitive and involuntary movements in your hands or your face or your neck, something that you cannot control because of the use of antipsychotics over such a long period of time. However, the risk of not taking the medication outweighs the risk of taking the medication, because schizophrenia left untreated will only continue to spiral into full-blown psychosis, mania, and other behaviors that are not conducive to adjustment in society.